The next condition we're going to talk about is acute pancreatitis, which is life-threatening inflammation of the pancreas. It's caused by premature activation of excessive pancreatic enzymes that results in autodigestion and fibrosis of the pancreas. So, as I mentioned, acute pancreatitis is characterized by early release of digestive enzymes from the pancreas. The two most common causes are alcohol abuse, so it could be binge drinking or alcoholism, or biliary obstruction. With biliary obstruction, you'll see an increase in the AST and the ALT, and that's a key point because that differentiates biliary obstruction as the cause versus other causes. There's like a list a mile long of conditions that can cause pancreatitis, acute pancreatitis. So anyways, with the autodigestion, the patient could develop shock, DIC, which is a condition of clotting and bleeding and clotting and bleeding, and you'll learn about it in mother baby. Adult respiratory distress syndrome can occur due to pancreatitis because it causes a systemic reaction. Locally, it causes severe pain, and they can have hemorrhage in the area, and peritonitis can occur. So remember that board-like abdomen, high WBC, and guarding abdomen, and hypovolemic shock may also occur. Pain in acute pancreatitis can be quite painful. It could be very intense. So it's usually in the mid-epigastric or left upper quadrant area. The pain is sudden and radiates to the back, left flank, and left shoulder. It's described as continuous, although it does wax and wane. So you expect it to get better and you expect it to get worse, okay? It's very intense and boring means patients describe it as ripping through their body, right? Your patient is going to be guarding for the pain. We discuss patients with pancreatitis having intense pain. So to relieve that pain, patients need to remain NPO and they need to maintain bed rest. The reason is because when you eat or if you're up and moving around, it increases your metabolism and it's going to result in more digestive enzymes being released from the pancreas. And we don't want that, right? The pain is going to be worse by laying flat or being supine. The fetal position provides a lot of comfort. Bending the knees really helps. So that's also called the left lateral decubitus knee bent position. They can also sit upright and lean forward a little bit, and that will also help with the pain. Now expect that pain to wax and wane. It may get worse. It may start to feel better. There are a lot of other complications that happen with pancreatitis, like they can get pleural effusions, they can have respiratory problems. So make sure you always maintain A, B, C, D, E before you take care of pain. But it is really important to take care of pain. We talked about acute pain and acute pancreatitis. The other expected findings include weight loss, nausea and vomiting. Cullen sign is bruising around the umbilicus, and gray Turner sign, sometimes that's shortened to Turner sign, is bruising on the flanks, and they indicate intraperitoneal and retroperitoneal seepage of blood-stained exudates. Paralytic ileus can happen. They may not have a paralytic ileus, so if you don't hear bowel sounds, you may have to put in an NG tube if they do have an ileus. So of course, ask about flatus, passing flatus. And they could, if they have an obstruction, a biliary obstruction, they could become jaundice. Fruity breath and warm, moist skin could happen because of hyperglycemia. Now remember that the pancreas also has an endocrine function of secreting insulin. So you may expect hyperglycemia in a case of acute pancreatitis even if the patient is not diabetic. The pancreatic enzymes, when they're autodigesting the pancreas, cause fat necroses, and these release free fatty acids, which then bind to calcium. Okay, so this means that patients with acute pancreatitis are going to have hypocalcemia. So watch out for the signs and symptoms. We talked about them last semester in MedSurg 1, but remember cats go numb, so you're looking for convulsions or seizures, arrhythmias, tetany, spasm, stridor, circumoral numbness and tingling, and also numbness in the fingers. Remember the positive Chvostek sign, that's when you tap the cheek, and Trousseau sign. So those are some assessment findings you're looking for. Remember the order of abdominal assessment. I went into detail in the A&P in assessment lecture. For somebody with acute ascites, you are going to inspect. You're looking for the gray Turner sign or the Cullen sign. Auscultate bowel sounds because they may develop a paralytic ileus. If they're passing flatus, they won't need an NG tube, but if they don't have bowel sounds and they do have a paralytic ileus, they will need an NG tube. Percussion, because of pancreatic ascites, percussion sound will be dull. And in terms of palpation, remember nurses only do light palpation, but the patient abdomen may be rigid and very tender and guarding, so they may have peritonitis. Okay, the expected laboratory findings are the findings you'll see in somebody with acute pancreatitis. I talked about amylase and lipase in the assessment lecture. And so basically, amylase and lipase are enzymes that are released prematurely from the pancreas due to pancreatitis. Okay, so the amylase is going to increase first, and that increases within 12 to 24 hours of pancreatitis, and it remains elevated for 2 to 3 days. The lipase is actually more sensitive. It increases a little bit later, but it stays elevated for about a week. Alkaline phosphate, bilirubin, ALT, those are all elevated due to biliary obstruction, and I've talked about them earlier. The white count will be elevated because it's inflammation. The BUN will be high because of hemoconcentration. Glucose could be high due to beta cell injury. Inflammatory markers are high. Magnesium will be low due to fat necrosis. Same with calcium. Albumin will be low because of third spacing. And prealbumin is the most sensitive indicator of malnutrition, short-term malnutrition. So if your patient comes in and they haven't been eating for a couple of days, they're going to have a low prealbumin. So that's a good test to look at as well. Nursing care involved in acute pancreatitis. You want to collect data on the respiratory system every 4 hours because patients with acute pancreatitis are going to be prone to a left pleural effusion. That has to do with the proximity to the pancreas with the left lung. And with this pleural effusion, they can get hypoxic. They can also develop atelectasis and then pneumonia. So that's why you're going to watch the respiratory status carefully, and that's going to be a priority. Of course, if they do have hypoxia, you're going to use oxygen PRN. The next thing we have to worry about is circulation, because patients with acute pancreatitis can sequester up to 6 liters of fluid, meaning 6 liters of fluid have third space and is not in the vascular system anymore. Okay, so they're going to need 2 large bore IVs, and you would do this for anybody you were worried about they were going to have hypovolemic shock. So 2 large bore IVs, so 2 18s, which are the green IVs, green colored IVs. Okay, so You're going to do fluid resuscitation, so that means you're giving large amounts of fluid to prevent the patient from getting hypovolemic shock. Hypovolemic shock, the first sign is going to be tachycardia, then tachypnea, and then finally hypotension. Hypotension happens later than tachycardia. You want to control pain, and we've talked about this before, so keeping the patient NPO and on bed rest to decrease metabolism. They're going to need a PCA pump, and they'll need antiemetics, a nasogastric tube, PRM. We talked about if they don't have bowel sounds, they're not passing flatus, they haven't had a BM, or they have severe vomiting, they're going to need an NG tube. Monitor for hypocalcemia. We talked about this earlier, that they can be prone to hypocalcemia. When the patient enters the healing phase, the diet changes a little bit. They're going to need small, frequent meals and snacks, moderate to high carbohydrate diet with high protein and low fat. Low fat is the important thing because fat really stimulates the pancreas. Supplemental protein shakes. Food should be bland with little spice. Avoid alcohol. Avoid caffeine. So remember, Coca-Cola has caffeine in it. Low fat and no smoking. Smoking increases your metabolism, so absolutely no smoking in acute pancreatitis. After repeated bouts of acute pancreatitis, the patient may develop chronic pancreatitis. This is usually due to alcoholism. The patient would develop diabetes type 1, which you know is unusual in adults. And this is due to chronic beta cell destruction. So they're going to need insulin, monitoring of blood sugars. So monitor patients with even acute pancreatitis. You would monitor them for the 3 Ps, check blood sugars frequently, but you also do it with chronic pancreatitis. They're also going to be prone to malnutrition because they can't absorb food, and you'll see that with weight loss and also muscle wasting. They will have steatorrhea, so they have those symptoms of biliary obstruction. So steatorrhea, jaundice, pruritus, dark foamy urine. So those are the signs and symptoms of chronic pancreatitis. Let's talk about PERT therapy. That stands for pancreatic enzyme replacement therapy. And usually it's reserved for chronic pancreatitis clients, but however, it can be used, ATI doesn't differentiate, can be used for acute pancreatitis if they're having a lot of steatorrhea. You should see an improvement in the amount of steatorrhea if the patient is on PERT therapy. So you need to teach all patients not to chew or crush enteric-coated preparations. They need to take it with all meals and snacks, and then they need to drink a full glass of water after they take it. Administer the enzymes after an antacid or H2 blocker because it decreases pH and activates the drug. If the client can't chew, pierce a hole in the gelatin casing and place the contents in applesauce. You don't want to sprinkle on protein-containing foods. Wipe the lips after because the enzymes are going to cause skin irritation. And then instruct the patient to follow up on labs because it may increase the uric acid in the body. And to evaluate the effectiveness, look for a decrease in the amount of steatorrhea. To recap, the diet is going to be eat bland, low-fat, high-protein, moderate, high-carb meal, minimal to no spices. Eat small meals frequently and eat high-calorie snacks. They may need protein, drink, supplementation. Avoid anything that makes the pain worse, such as caffeinated beverages, alcohol, high-fat foods. No nicotine or smoking, because that's going to increase the pain. Pancreatic enzymes, they have to take that with all meals and snacks and follow with a glass of water. Living area, if somebody's going home from acute pancreatitis or chronic pancreatitis from the hospital, ask about stairs in the house because they really need to be limited to one area and they're going to need a bedside commode if they have steatorrhea. And then with what to report, you have to teach your patients to report an increase in frothy urine and fatty stools, because that means biliary obstruction. Of course, if they have jaundice, they would report that too, and teach them about the 3 Ps of diabetes if they previously were not diagnosed with that.